GYN services in low resource settings. Thank you, Dr. Daisy.
Thank you very much, Dr. Harris, and I really appreciate all of you for coming in to listen to us this afternoon. So I'll share a little bit about the barriers that we see out there in terms of what the women experience in trying to get care in obstetrics and gynecology. As per the introduction, I am Daisy and I work for Chepaigo, Kenya. I work across several projects, but in general, I am supporting projects across the surgical portfolio, postpartum hemorrhage, cervical cancer, and the obstetric fistula. So really, all those challenges that women face accessing services. So this is a map of Kenya. It's organized in terms of counties. There are 47 counties, and we operate within a devolved healthcare system for about 10 years now. Previously, we had a pretty much centralized system, but for the last 10 years now, each county government then decides which services they can have for their citizens, how many doctors they can have, how many they can employ, procure the commodities, the drugs, infrastructure for each of their facilities in those counties. And it is organized in levels. So in Kenya, we have level 1 to 6. And level 1 is really the community. At the community level, we have community health promoters. Those are those non-clinical personnel that link the women from the community into the facilities. And then level 2 is the lowest health cost, which is dispensary. And then level 3 is health centers. 4 and 5 is hospitals. In Kenya, we have 4 sub-county hospitals. And then the county hospital is the main referral hospital within the county. And then we have tertiary institutions, currently 3 in the whole country. So it is organized in terms of what specialties that they can be able to offer in these facilities. Kenya, we have a population of slightly over 50 million, I believe 41 now, possibly in the next census a bit more. Yeah, and we do have a lot of challenges with the healthcare system in Kenya, but just to highlight a few of these, one of the biggest challenges is limited access to quality healthcare services. We have a shortage of healthcare personnel. We don't have enough doctors in general. We don't have enough specialists. For example, like in Rwanda, the main cadre that will offer the cesarean section or the primary services at a hospital that is level 4 and above will most likely be a GP equivalent here. And we may have only 3 specialists or 1 within a whole county. So they are not able to conduct the cesarean sections. The facilities are not equipped. And then we have a national health insurance fund, not affordable to the general population. It costs about $60 per year. That's very expensive for any Kenyan who is not employed. And then, like any lower middle income country, we have a high prevalence of maternal and infant neonatal mortalities. There are many challenges, of course, associated with that, we end up getting a lot of complications. It stems from delay in these women seeking care at home, first making the decision, then getting transportation to the facility. But while they are at the facility, then we can even experience a third delay where there is a challenge with making the decision for care. For example, how long even we take to perform a cesarean section while the mother is in the hospital. But it's not even always because of the hospital or the provider. If we have one theater and you have 3 clients for cesarean section, the surgeon is on the table operating, and then they get, a cord prolapse, there's 2 more. So they do queue for theater, and of course, that's a very big challenge, because then we are reducing the likelihood of getting good outcomes. We don't have the kind of infrastructure support like we have here. So prenatal care or neonatal care after delivery is a challenge. Then we have a big problem, and this is more less like Africa, around cultural or societal factors, a lot of stigma and discrimination, generally related to issues around reproductive health. And that affects women because if the husband is responsible for giving her the money to take the bus to go to the hospital, then that way there's already, issues around gender imbalance, and it can affect her care. She will not go for her ANC and even her postnatal care or any gynae review or her contraception for that matter. And then women don't have access to information, so they don't know what information they need for their care, and they don't even know where to get that information. I wanted to show this just to show what kind of challenges we have both across the gynae and the obstetric areas. And for us, hemorrhage is a big issue, followed by hypertensive disorders and sepsis for the causes of maternal mortality. You can see just the 3 top causes are slightly over 50%. So when we think about interventions, then we are aiming to actually address those particular causes. We have an MMR which is quite high at 362, way off the tangent when it comes to where we should be, less than at least 100 per 100,000 live births. And then for the gynae cases in Kenya, the most common cause of any gynae cancer is breast cancer, and then followed by cervical cancer. But when it comes to death, we see, cervical cancer is the leading cause of death, of course, because of challenges with these women at going for screening and ultimately, late diagnosis. So they present quite late, and then we are not able to intervene on time. And so our women need access to quality of maternal health care services. They need family planning and contraception. We need to be able to manage and manage complications, prevent the complications around those top 3 killers, and other complications such as obstetric fistula associated with delivery. And then we need to have access with access to cesarean section. So if we're having this many facilities, but for her to be able to reach a site that has a theater and able to offer this, then it's still a challenge. So we need access to CMONC sites. We need access in terms of increasing access to screening for cervical cancer, as well as breast cancer. In Kenya, we have a challenge with the abortion. It is illegal in Kenya. So we can only address post-abortion care, but then that's still a challenge. And from the Rwanda case, issues even as easy as an MVA kit is a problem. And also skills to be able to offer that care. Then we need access to quality medicines. We have in Kenya challenges with supply chain. Some medicines need refrigeration or special care, and if we are not maintaining that cold chain, then we are compromising the quality of these drugs that we are giving our women. The women need health education. They need a lot of information. We need to be able to package that information in the language they understand, in the simplicity that they would get the message, and even start thinking about self-care. And then, of course, for us in Kenya, we still deal with issues of GBV, gender-based violence. Even with intimate partner violence, we have communities that still practice female genital mutilation. And FGM has consequences. For example, when they come for delivery, depending on how extensively it was done, then they do get complications during delivery. We have issues with having very young mothers, so we have a lot of adolescents who also get pregnant, and they also do get complications. So I tried to classify these barriers to access across some common themes, as we shall see. So geographical barriers, issues like lack of facilities in general, and this is to the remote areas, and then distances between these facilities could be so big. It could be 100 kilometers if you're trying to refer a mother from that facility to the referral site. You're going to get a poor outcome, or even lose this mother as we do the referral. The roads can be a big problem. Some roads are seasonal, so you go with the ambulance and then you find a flood, you can't cross. The woman is on the other side, so quite a challenge with that. And then financial issues to do with the treatment costs. How does this woman afford her care, the tests, the medications, the procedures associated with that? But even more importantly, she requires to pay for her transportation. She doesn't have her own private car, so money is important to move her from her home to the facility. And then what about the time the husband has spent away taking his wife to the hospital? They've spent the whole day traveling. He doesn't get to work that day, so the cost of lost wages. And then the healthcare system has a lot of challenges. We have a shortage of workforce. We don't have enough specialized training. We don't have enough specialists. Infrastructure is basic. We don't have the kind of infrastructure that we see here at University of Utah Health. Sometimes you have to share one room, having different services, seeing the child there, the mother here, doing a HIV test here. So we work within those constraints. And then there are not enough facilities to offer surgeries like cesarean section to these mothers. Limited availability of medicines. Women even who need a contraceptive don't necessarily get their choice. She might want an implant, but she comes in and there's only an injection of DMPA, and she will have to take what is available. And then we often lack equipment. We may have a cesarean section set, but it will not look anything like what we have here. So we may have very few equipment. within that set, but we will have to work with it. Issues like water to prevent, I mean, it's very important in preventing infection. Can be a challenge. It's not always piped, and we have to innovate around that. Electricity with a lot of interruptions, or sometimes even outages for days. We may have solar to supplement that, but again, that's a challenge. It's a system that needs to be maintained. If it breaks down, nobody repairs it. We have fridges with vaccines and medications. What happens to that? They all, get spoiled, and you're not giving effective medication to the women. And then we have poor referral systems. We may have a strategy, but if we don't have the ambulances, we don't have the trained personnel within the ambulance to transfer this mother again, those are big challenges. And I just wanted to show this picture. That's me, I think, in one of the rooms in labor and delivery, just the resources that you have. And, this is a hospital in Kenya, in a county where we work, called Makueni County. You can imagine it's a room full of beds. There are 3 rows. I'm not sure we are managing the distance required by WHO between the beds, and we have curtains for privacy. So resources is a big issue for us in Kenya. And this is how a typical OT would look like. You can see it is very basic. We don't have all those machines that you have here. Again, just showing, the challenges. And these are some of the scenarios that we have. I think the picture at the bottom, that lady could be in labor. She's barely able to hold on to the motorbike, and she's going to hospital. It's the only means of transport for her. In some other places, we may have even a donkey, cart as the ambulance for the mother. Of course, we do have in the cities, proper ambulances, but in the rural areas, we may see this kind of situation. So we have also client-specific barriers, and a lot of them have to do with their society they live in, the cultural nuances, their beliefs, stigma around reproductive health, cultural practices that I mentioned, like FGM, gender imbalance, where, it's an extremely patriarchal society. So the man decides when you go to the hospital, he needs to give you money. You shouldn't, or even you should not work. So the women's autonomy and decision-making becomes a challenge for their healthcare. And then the issue of lack of awareness and education. Literacy levels in this country is quite high. Particularly one county which I mentioned, it's about 61%. That's very high. So we would need to translate even any educational materials we have to the local language. There's generally a lack of awareness when it comes to what services are available for them in these facilities. The need for them to go for their regular checkup screening, for example. They don't know any signs or symptoms for those conditions that they do suffer. And then we don't have comprehensive sexuality education in our system. In fact, it's really a challenge to have sexual education in the lower the primary schools because of the laws that are limiting. And then, of course, there is a lot of poverty, social marginalization for some groups. We have obviously vulnerable populations, for example, women from ethnic minorities. Adolescents don't even like to go to the facilities because the providers are not trained to provide services for them. So they'll be asking them, why are you not in school? Why are you pregnant? You know, instead of talking to this adolescent, counseling her, offering her the choices that she might have, you know, after delivery, family planning, and a back to school plan. So those are all challenges. We have a huge humanitarian camp in Kenya for people from Southern Sudan. And there are challenges in that humanitarian setup. Other challenges around data, we have a DHIS system in Kenya, but then how well does it work is the challenge, is the quality, is the data of quality that comes from that system. We have challenges with the primary tools like registers to collect data. We don't have enough of the electronic data systems in Kenya. And then issues around policy, we do follow WHO, but we are not always adapting the guidelines on time so that we are able to help these women. And then there has to be political goodwill. You can have all these good technologies, all these guidelines, but if there is no investment for improving these OBGYN services, then that's a challenge. The country has to embrace technology, has to say, yes, we can use this technology in health. And if that goodwill is not there, then nothing happens. It also speaks to, you know, collaborating with other, you know, bigger brothers, other governments, other developmental partners like the donors. That community is very important for us. So in addressing these challenges, we really need that multifaceted approach, just to look at healthcare, you know, in that lens of all the health system building blocks, for us to focus and plan for these women and children. We need to sensitize the community for all those cultural and gender issues. And of course, some of the challenges we have, we can actually address by embracing technology, whether it's mobile technology, AI, or whatever that would really help us, especially anything that comes to help out the issue of shortage of health workforce, because it's a big issue. If we have technology that can support, that would be very nice, and it's good for government to embrace that. So I wanted to share about my programs. So implement an obstetric fistula program. Very challenging. The picture on the left-hand side, those are actually the community health promoters that we are training. We don't always, in the community, we don't always have space, like a good classroom, and we go there and train them in their setup. And this is just how it looks during the training. And this is a woman, the one who, the tiny lady, is one of the women that had a repair. They have a challenge getting back to the facility. So we usually have a team of a social worker, a counselor, and a nurse actually visit them in their homes just to see how they are doing, whether the repair did take up, they're not leaking anymore, any challenges. And if there's a challenge, we arrange for her transport back. That means we actually pick her, take her to the hospital and back. And also this is just a picture of one cohort that was in the ward then. And the purpose is really to tell you, we have the oldest women who have fistula for 40 years, 30 years, 20 years, and we have very young ones. You can see an adolescent or very young girls. It's really a mixed group when we see them, and they were very happy about their service providers and wanted to take a picture with them. And then just to share that we are integrating technology for virtual support during cesarean section. We are using a platform called Proximi, and it's really AI during the cesarean section. We use it for life support. So that means a gynecologist, obstetrician, from the comfort of wherever they are, can get an invite, and then they log in, and then whatever challenge that the medical officer or the young doctor, who is probably 200 kilometers away, can get assistance, because the technology uses cameras that have been installed in the operating theater, with one particular focusing on the cesarean section site, and magnifies it for over like 20 times. You're able to really see and help that doctor navigate and make sure the woman survives, because the cost of transporting her to the next site, or the gynecologist or obstetrician traveling to that site, would be more than 1 hour. We may not get a live patient if it's postpartum hemorrhage. So just helping them do this clamp here, there's a bleeder here, tie. It has annotation, so it has a remote hand to even show where this doctor can actually put the stitch. You can even show using a scalpel, a needle and syringe, and help them navigate the whole cesarean section. We've had young doctors end up doing a subtotal hysterectomy, which they've never done, but for that purpose, they have to do it to save the patient. Even if the obstetrician is on the way, but at least the patient is alive. It's not only for life support, we use it for telementoring. So the obstetrician in the central site invites the other medical officers for a case she wants them to learn about. So they all log in and watch as she performs the procedure. Then the gynecologist obstetrician can record cases into a library, and then in that library, then you can go in and review. And you can also have audits about how a cesarean section went, what could have improved. And yes, these are some of the statistics just from that county. Emergencies were close to about 100%, actually 98. We managed to bring them down a little bit. The CS rate is down to about 28.1. We are tracking surgical site infections. We've introduced infection prevention bundles, and we are adhering to the cesarean section rate. That's just one of the screens inside the operating room. And then my last one, which I want to mention, we are adopting WHO recommendations, and specifically around PPH, and we are introducing heat-stable carbetocin into the public healthcare system. It is an analog of oxytocin, and as the name suggests, it doesn't require refrigeration. It's heat-stable. So for us, where we have challenges with maintaining the cold chain because of electricity, temperatures, then this is an option for us. Thank you.
I'm a bit over, but I wanted to thank so much Dr. Udall and Dr. Lindsay for their wonderful presentations and for the Center for Global Surgery for putting on this session, as well as the Department of GYN and Surgery for their support of this programs. If anyone wants to ask questions of Dr. Lindsay or Dr. Udall, please feel free to come up. Make sure you grab lunch as well on the way. Thank you so much, everyone.